2 AV block. How is it different from the secondary top 1? So a top 1, going back from review, we have an increasing PRI until we just drop a QRS complex. So the AV node holds on to that stimulus or stimulus from the atria a little bit longer each time before it sends that information down to the ventricles. And then sometimes it just doesn't send it, but it seems to be a routine pattern. So increasing, then we have a drop beat. So when you see that with a top 1. However, what's happening with a top 2? With a top 2, the block occurs at or below the bundle of His. So going back from review, the AV node, if it's happening at the AV node itself, we're dealing with a first degree, a secondary top 1, or a complete or a third degree AV block. So if we're dealing with a top 2, it's going to be happening in the bundle of His or somewhere in the bundle branches. So the SA node is generating the impulse in a normal manner, just like it would in a sinus rhythm, just like it did in secondary top 1s. So there's no changing with the cardiac conduction in the atria. So the SA node fires, send the impulse over to Bachmann's bundle, internodal pathways, depolarize the atria. That impulse makes it to the AV node. The AV node holds on to it and sends it down most of the time. So what's happening when I say most of the time it sends a signal from the AV node down, but occasionally it's blocked. And sometimes maybe more frequently than we would prefer. Impulses generated by the SA node are conducted to ventricles at the same rate until the impulse is suddenly blocked. So with a top 1, secondary top 1, we have an increasing PRI. That AV node holds on the impulse a little bit longer each cardiac cycle. So it holds on to it a little bit longer, holds on to it a little bit longer than previous, then holds on to it and just doesn't send it. With a top 2, the length of time the AV node holds on to the impulse from the atria is the same each time. We just have randomly dropped beats. It sends it, or receives it, sends it, receives it, sends it, receives it, sends it, receives it, doesn't send it. Maybe receives it, doesn't send it, receives it, doesn't send it. So, but the key factors here is looking to that PRI interval. So P wave, smooth, upright, one P wave, the PRI is constant, so versus lengthening. So the PRI is the same, we're constant. So we have normal P waves, regular P waves. The problem becomes with the QRS complexes. So in this case, we have P wave, P wave, P wave, P wave. So overall, the rhythm is irregular. Why? Because we have randomly dropped QRS complexes. But if you were to measure the P to P interval, the P to P atrial rhythm is regular. So we have P wave, QRS, P wave, QRS, P wave, no QRS, P wave, no QRS. So what's happening here? And this time, the SA node's firing, sending that signal out, AV node holds on to it and sends it out. Same thing repeats. SA node fires, atria holds on to it, sends it out. This instance, SA node fires, sends it out, AV node holds on to it, doesn't send it. Same thing, AV node receives it, does not send it. AV node receives it and sends it. So notice we have these complexes, which is randomly dropped complexes, but the PRI is the same. The PRI is constant. So if you were to measure these PRI intervals, they would be the same. Obviously that doesn't have a PRI. So these PRI intervals are the same. So going back and review, atrial rate is faster than ventricular rate because we have randomly dropped QRS complexes. The rhythm, atrial rhythm is regular. Ventricular rhythm is irregular because we have a random drop beats. P waves normal in size. They look like sinus P waves, as you can see. They're smooth, rounded, upright. So it tells us it's coming from the SA node. Problem is we have an issue with a PR interval. So it's not necessarily the length of the PR interval, because sometimes we just don't have a PR interval because we have a dropped QRS complex. So the PR interval is usually within normal limits, maybe a little bit longer depending on how sick the AV node is. But when we do not have a complex that follows a P wave, we have no PR interval. So, but these PR interval is the same or constant, we'll say constant, when present. So again, you have to have a QRS complex for the PRI to be present. So QRS is usually greater than 0.10 seconds, periodically absent after the P waves. Again, these may be longer depending on how slow the conduction takes through the ventricles. So different causes: left coronary artery disease, anterior wall AMI, acute myocarditis, other types of organic heart disease are all possibilities. Significant slowing of the ventricular rate commonly results in serious signs and symptoms because that rate's going a little bit slower, have a poor contraction or conduction through the ventricles, so they may have a little bit more serious signs and symptoms or significant signs and symptoms. A secondary AV block 2 is usually indication for a permanent pacemaker. So, what are you gonna do with it? Again, same thing as any other thing, any other patient. How is this affecting your patient? Just because we have this on the monitor does not mean we need to treat it. Keep that in mind. We treat the patient, not the monitor. So, if your patient is exhibiting signs and symptoms of poor perfusion, hypoperfusion, hypotension, arterial mental status, poor skin color, all those are factors to consider in the treatment. Whereas we can still consider increasing heart rate by administering atropine. It may not be as effective as it would be in any normal bradycardic, sinus brady, first degree, or secondary type 1. So you may have to go a little bit more aggressive with second degree type 2 and start pacing your patient. So again, let's review. What do we have? Secondary type 2, you have one P wave. P waves are upright. So a P wave, you have QRS complexes, your P to P intervals regular, your Q to Q or R to R intervals irregular because we have randomly dropped beats. You have this constant or same PR interval when the conduction occurs. You just have randomly dropped beats. So versus a type 1, with type 1 you have increasing PRI until you have a drop beat. So biggest difference between a secondary type 1, secondary type 2 is the PRI. Is the PRI the same or does it lengthen? If it lengthens, it's a type 1. If it's the same, it's a type 2.